Kawasaki disease is an acute systemic vasculitis of the medium-sized arteries, which is the leading cause of acquired heart disease in children. Kawasaki disease begins with abrupt onset on high and spiking fever, usually unresponsive to antibiotic. Diagnosis is based on clinical criteria which were established by Center for Disease Control in 1985. The classic diagnosis based on fever for 5 days with at least 4 of the 5 principal features like polymorphic rash, erythema of the hand and feet with periangual discommission, bilateral non-purulent conjunctival irritation, cracked-lipped strawberry tongue, and erythema of the oral mucosa is called and associated with unilateral cervical lymph adenopathy more than 1.5 centimeter is called complete Kawasaki disease. Besides, some patients do not meet the classic criteria, showing only 2 to 3 criteria along with fever is called incomplete Kawasaki disease. Another terminology is atypical Kawasaki disease, defined as Kawasaki disease with unusual presentation, occurs more often in infants. Kawasaki disease may involve in pericardium, myocardium, and endocardium, may involve the cardiovascular system, musculoskeletal system, gastrointestinal system, central nervous system, and respiratory tract with different types of presentations. The cardiovascular complications that develop during the acute phase of Kawasaki disease may involve the pericardium, myocardium, endocardium, and coronary arteries. Pericardial effusion is approximately found in 30% patients with Kawasaki disease. Coronary artery abnormalities develop in 20 to 25% of all affected individuals. Echocardiography is useful in recognizing these manifestations. The most common findings are coronary artery abnormalities, dilatation, aneurysm, and ectasis. Other than coronary arteries, aortic root abnormalities, valvular dysfunction, myocardial dysfunction, and pericardial effusion may be found. These are some echo features of coronary artery dilatation and aneurysm. The next steps are the lab findings. Laboratory findings may be present with neutrophilic leukocytosis, thrombocytosis, anemia, elevated ESR, CRP, alpha-1 antitrypsin, serum immunoglobulin E, and may present with hypoalbuminemia, proteinuria, sterile pyuria. ECG may show features of myocardial ischemia or infection, or may raise the cardiac enzymes level. The main treatment option is intravenous immunoglobulin with high dose aspirin, usually within the 10 days of onset, which decrease the risk of coronary artery aneurysm. And second dose IV immunoglobulin or pulse methylprednisolone and other immunomodulating therapy are indicated in case of refractory Kawasaki disease or complicated cases. If the fever persists more than 36 hours after the IV immunoglobulin, is called the refractory Kawasaki disease. The prognosis is based upon the extent and severity of coronary artery involvement at diagnosis and follow-up. The highest risk group is with large or giant aneurysm. Those require much closer cardiac monitoring with some anticoagulant therapy. These are the differential diagnoses of Kawasaki disease. Now, I want to show a data of 7 months. This was a single center retrospective study of 149 children. During the survey period, 149 children were diagnosed with Kawasaki disease at the Leavitt Cardiac Hospital based on clinical features by Professor Brigadier General Nunar Fatima. The prevalence of coronary arterial dilatation, regression, and changes were documented. Total number 149, male and female ratio 1.8:1, and coronary artery internal diameters in the LMCA, LAD, LCX, RCA obtained by echocardiography were converted to Z score by using body surface area. According to AHA guideline, up to 2.5 standard deviation is dilation only. Up to 5 standard deviation is called a small aneurysm. 5 to 10 is medium aneurysm, and more than 10 is for large aneurysm. At diagnosis, total 32 patients had cardiac complications, and the frequency of involvement of coronary arteries are as follows. LMCA 48 out of 132, 36%, LAD 37 out of 132, 28%, LCX 11%, RCA 24%. Among 132 patients, 48 patients experienced dilatation of the coronary arteries, and 84 patients suffered an aneurysm. 33 had isolated LMCA aneurysm, 24 had LAD aneurysm, 19 had RCA aneurysm, and 7 had aneurysm in the LMCA, LAD, and RCA. 10 had aneurysm in all 4 coronary arteries. After diagnosis, children treated with single infusion regimen along with high dose aspirin in divided 4 doses until patient is afebrile, then 3 to 5 milligram per kg, and discontinued aspirin 6 months after the onset of illness if no coronary artery abnormalities are observed on echocardiogram. Single infusion regimen has significantly lowered the coronary artery abnormalities. Regression of coronary arteries segment was documented if there was Z score reduction more than 1 in between the initial evaluation and follow-up evaluation. After the 2 weeks after the enrollment, 50% echo findings became normal, and by the 7th week after the enrollment, most patients with Kawasaki disease have good clinical outcome. Only 3 had abnormal findings. Though those 3 who had abnormal findings in the coronary artery, their Z score lies on the just below the 2.5 standard deviation. Regression of the coronary artery segment was documented if their Z score more than 1 between the initial and follow-up evaluation. And few of their affected coronary arteries took more times to return to normal. The patients are on, those who had abnormalities in the coronary arteries are on tablet aspirin and on regular follow-up. So the key message is administration of intravenous immunoglobulin and aspirin with proper doses in the proper duration has greatly reduced the incidence of coronary lesions in the affected children. Some other immunomodulating therapies have recently been utilized in complex or refractory cases, and recent advances in research on Kawasaki disease for genetic susceptibility and immunopathogenesis. So early detection and timely management is the dire requirement for Kawasaki disease.